Hi, so I'm Stephen Haskins. I'm an anesthesiologist. I work at the Hospital for Special Surgery, which is an orthopedic hospital in New York City, and very excited to be talking to you about point-of-care ultrasound.
So tell us how you use point-of-care ultrasound. Generally, what it is doing.
So my use of point-of-care ultrasound allows me to evaluate patients at the bedside where I'm concerned about a potential obvious pathological source for hemodynamic instability, respiratory distress, or if I have any other sort of clinical question that needs to be answered urgently at the bedside. I often describe point-of-care ultrasound as the 21st century version of a stethoscope. And so now, instead of just being able to listen to our patients, we can actually look inside of them and be able to assess for that obvious and potentially life-threatening pathology. And that's really where it can make a big difference in terms of changing patient management, and also can actually put you in a position to save a patient's life, depending on the urgency or the emergency of having that clinical question answered.
Could you give me a couple of examples of how point-of-care ultrasound, some conditions where a patient might be in big trouble and speed to diagnosis and understanding what's being done?
So I can give you a clinical example of a patient who, following spine surgery, was hemodynamically unstable, in respiratory distress. There was a concern potentially following having a lateral approach, which involves the abdomen, that they might be bleeding into their abdomen. And so I was called to the bedside to perform a fast exam to look for signs of blood or any other fluid within the peritoneum. And to my surprise, there wasn't any fluid in the peritoneum, but as I then went to look at the heart and the lungs, it was very clear that there was a great deal of blood surrounding the lungs. And so it pushed us in the direction of realizing that this was more of an issue with bleeding into the thoracic cavity instead of into the peritoneum and into the abdomen and pelvis. And having that information at the bedside, instead of having to wait for a CT scan or a chest X-ray that may not provide that information in as rapid or in as meaningful sort of definitive way, made a big difference. Allowed us to change our trajectory. Instead of thinking about rushing that patient off to the OR for an XLAP, we contacted thoracic surgery instead to deal with the bleeding into the thoracic cavity. So that's just one example of point-of-care ultrasound, resulting in change in management and potentially saving this patient's life. Because if you were to open this patient up and start looking in the abdomen and not be able to diagnose and treat the cause of the bleeding, then might have ended up in a much worse clinical outcome.
I don't think we're very good at this. Doctor, is there another example you could give that is patient safety item, for instance, or something else where point-of-care ultrasound really allows you to head off something much more serious, or let you get to a disposition where you can move to the next thing?
Yeah, so one of the sort of underutilized skills in anesthesia is lung ultrasound. And the reason for that is, we as anesthesiologists, I think, gravitate towards echocardiography because of our experience with transesophageal echo. But there's a lot of respiratory pathology that is incredibly relevant to us as anesthesiologists. And patients present in respiratory distress for a variety of reasons, some that may actually be the result of complications from our procedures, like peripheral nerve blocks, where if we were to perform a nerve block near the lung, we could potentially cause a pneumothorax, or if we're performing an interscalene block or a high brachial plexus block, we actually can paralyze the diaphragm and cause hemidiaphragmatic paresis, which can, for a patient who at baseline has respiratory insufficiency, result in a respiratory failure. And so our ability to look at the lung at the bedside and differentiate between a wide variety of causes of respiratory distress, be it a pneumothorax or an interstitial process for a patient who has congestive heart failure and may be presenting with fluid overload after surgery, or a patient with COPD who alternatively now is presenting with a hyperinflated lung. No sort of B-lines is what we would be essentially looking for as the ultrasound artifact, or also looking at the diaphragm and being able to assess for diaphragmatic function after performing a nerve block. All of these things allow us to guide management and give us information that is more rapid and often more accurate than if we were to order a traditional diagnostic modality like a chest X-ray. So ultrasound-guided regional anesthesia has transitioned from sort of a novel technique in the last decade to something that is used ubiquitously across America and internationally as well. And we use ultrasound for almost every single type of nerve block that we perform at our hospital, for special surgery. And the reason for that is it has allowed for more rapid placement, more accurate placement. We can actually use less local anesthetic to have the same effect in terms of our nerve block. And it's allowed us to perform nerve blocks like the adductor canal block, for example, which is more of a fascial plane block to a certain degree because we have to visualize the adductor canal underneath the sartorius muscle. And that's not something that you can use nerve stimulator or paresthesia techniques to identify the saphenous nerve, but it makes a big difference for patients immediately after surgery to have quadriceps strength and to be able to work with physical therapy, while a femoral nerve block or a fascia iliaca block, on the other hand, causes weakness in the vastus medialis and the quadricep muscle. So this has allowed us to provide potent analgesia for patients, minimize opioid requirements after painful surgery like total knee replacement, and also facilitate ambulation so that way they're able to get up and work with physical therapy sooner. So these changes are a direct result of being able to use ultrasound to visualize either fascial planes or nerves in areas that before were not suitable for something like nerve stimulator or paresthesia technique.
To head off opioid problems using this, getting started using this, using that as a
Yeah. I would say that most people at this point consider regional anesthesia part of a multimodal analgesic regimen. Whenever possible, either using a regional technique, be it a fascial plane block or a nerve block, or even a neuraxial technique like an epidural. Yeah.
At 3 different locations. Compete in exciting video games for daily prizes and see if you become a Simulate Challenge champion.
Talking about the multimodal.
Yeah. So I think most people at this point would consider a regional anesthetic as part of a multimodal analgesic technique to minimize opioids after surgery. Be it a nerve block or a fascial plane block or even some of our neuraxial techniques like epidurals postoperatively, it makes a major difference to be able to minimize the need for opioids in the initial days following surgery, where the acute pain is the most severe. Given the opioid epidemic and the concern of a lot of surgeons and patients that opioids will result in tolerance or addiction, and also divergence of these medications, patients, surgeons, and the medical community is looking for these unique ways to minimize opioid requirements and needs, and regional anesthesia has been catapulted to the front lines when it comes to treating pain postoperatively.
Jody, what is it? How would you like that last boost to roll out to the team?
So, really what we're trying to do is just give them some kind of words of encouragement, essentially, because, they're working, you're an engineer working in a cubicle working on, a transducer, and wondering, like,
Keep up the good work.
yeah, essentially, like, keep up the good work. I mean, what you're doing makes a difference.
Yeah.
Even though they don't see it, they need to know it truly does make a difference.
Yeah. Okay.
Yeah, for the guys in the trenches.
Yeah.
Yeah.
Fair enough. Yeah.
Even if you say to the internal sonocyte team.
Yeah.
Okay, thanks for everything you do.
Yeah. Okay. That's good. I like that. So I just want to say to the internal sonocyte team that the work that you've been doing over the last several years, particularly when it comes to ultrasound-guided regional anesthesia and point-of-care ultrasound, is making a big difference in terms of our ability to manage patients in the perioperative setting. The advances in terms of the hardware, the imaging that we're getting from these probes, and also the machines and the software, the educational elements that we're seeing on a lot of the machines, it makes a big difference for those of us who work in training environments. We're working with residents and fellows to be able to use these tools to teach them how to best manage our patients and really make a difference. So I've sort of seen the evolution of sonocyte machines. Our hospital has a fleet of sonocytes, and we've been using them for many years. And the latest iteration, is something that I've been incredibly impressed with, and we're very fortunate to get the type of support to when we're teaching workshops in and around the country and the world, to have sonocyte machines to ensure that we have the best imaging and the best quality when it comes to image interpretation. So thank you for what you're doing, and keep it up. That's good.